Professor Panchnathan. I'm here to share or possibly delve a little bit into how insights from data can augment delivery of patient care. So here is a term that we all have heard of, many of us, about health IT. But it's not about the technology, right? Swami often uses the pun of technology. Luckily, we have an information that's prior to it, that's placed as a prefix in front of technology, wherein we are talking about where, what, how, why, if it is used, it can be really helpful. So I'm going to a next terminology, informatics. It's the term that I would like to use because technology is only an enabler. Proof of the pudding is in eating, right? So how information about in practice of medicine is gathered, shared, and utilized. But ultimately, what's the fun of doing all of these is to exchange knowledge and possibly draw some insights out of it, which is going to actually achieve our goal. If there is obviously there is a goal that we would like to achieve, that is best possible treatment to a patient that's being offered. If that is something we are able to do it, then wonderful. IT enables that to happen. So we would probably need to term it as applied clinical informatics. So as even Professor Panchnathan mentioned, it all begins with automation of processes, automate tasks to obviously streamline operations. But going from there, we want to look at enhancing care, improve the diagnosis, prognosis, or possibly even predicting outcomes. And yesterday we had a discussion on care continuum. So IT plays a role as well there. But of all, in the end, you need to top it up with if we are able to implement adaptable models and which are scalable and as we go by. So in the healthcare value chain, patient is a core. So you have a lot of information that is getting generated by various systems around, be it the health information system, which possibly is the first and the core of it. And you have the picture archival communication system, which handles the medical images and the pharmacy and whole host of systems people may be talking to you about probably in a hospital or even the other setups around. But the core is the patient, and there's a symphony of, I would say, information that is getting generated, exchanged between various systems in order to deliver the best possible care to the patient. And HIS itself and health information system itself, obviously, is utilized for handling various processes at the outpatient, inpatient levels, and various support systems are there. But again, the core is a clinical information system, which enables clinician to put in the right data and possibly get the information that could be used for further treatment. So with all this data that is getting generated, what is the biggest benefit of informatics? It's about how we can make this actionable. If this is not actionable, as an IT professional, everybody would say it's a junk in and junk out. So it is about how information is utilized and put into action for the benefit of the patient care. Here, in the next few slides, I would take, possibly I'm trying to highlight what that we do for efficient management of patients, be it from the clinical perspective or from an administrative perspective. We have the various committees in the hospital which look into the best on managing the patient. So we have a patient welfare committee, which possibly in one of those reports or dashboards that we use is for the for monitoring readmissions. As you would see it here in the slide, it's just a representative image, but you would be able to see various information with regard to that patient treatment in the hospital when he was admitted. Was there a prior surgery? Was he getting readmitted? And what information is there? Obviously, we are looking out if there is a readmission, what could be the possible reason? The next being analyzing re-exploration. Obviously, you are looking at if there is a deviation in protocol or a change in the protocol, or is there a possible risk of adverse events, which is making the patient get back for a re-exploration. The long stay monitoring, obviously, is something which everybody would be concerned about. Shorter the stay, the lesser the risk of hospital-acquired infection, be it due to comorbidities or anything else, is something which needs to be analyzed. All of these are available on obviously on a click of a button, wherein the management can look into it and take appropriate actions. Here I have a projection of the data that is actually entered by our nursing team with regard to the lines and the tubes and the various things that are put into a patient, so that we are effectively able to monitor even the infection. So we have an infection control dashboard which projects the postoperative patient's details along with the antibiotic data. What are the various antibiotics the patient is having, the organisms isolated, and which are sensitive and what is resistant to it, and what are the relevant lab values projected parallelly to it for drawing insights. And the relevant information can be gathered by the infection control team to take it further. Of course, the mortality report, and obviously it's less than 1% in our hospitals. That's a great thing to achieve. So moving from what possibly where the patient is inside the hospital, how the clinical management happens, and we will just move on to the telemedicine aspect, which is something we practice, and we heard a lot about it yesterday. Uh, the way the post-operative patients are, how the patients are followed up from the West Bengal and Orissa states, which are farthest from be it Puttaparthi or Bangalore, and patients come from. So when we were trying to look at the cost effectiveness of telemedicine, it's more than about assigning a value to for a consultation that possibly may happen. We were looking at how effective it has been by taking into consideration a patient perceived utility scores. Then we added upon obviously the opportunity lost. The patient forgoes his labor, and when he has to travel to Puttaparthi or to Whitefield for his follow-up, we realized that TM care, the telemed care, dominates the inpatient care strategy, even if it is somewhere, if it is termed to be non-successful. What I mean by unsuccessful telemed consult, it is where he needs to necessarily come back to the treatment center, or wherein he is identified to have a problem which does not actually belong to the primary specialty where he was treated under. He is detected to have some other challenge for his which is being referred to. Looking at cost effectiveness, it was an interesting model that we could come up to understand between the routine care versus telemedicine care. What are the key parameters that impact it, and possibly what is the ideal place to locate a telemedicine center, considering the distance between the telemedicine center vis-a-vis the specialist center over here. What would be the facility cost per annum that we would have, what the work days lost in routine care for the patient, the success rate, as well as the number of patients visiting the telemedicine center. So this was a kind of a cost effectiveness ratio of the TM care that we could achieve, and it was published in a reputed journal. Now, moving on to the financial aspects, or the what would an admin also would look at is, even this is presented to the managers of the departments, where one would, because we operate on monthly budgets, right? Being a trust-based hospital, we have budgets for each of the departments. So we plan how many cases you would have to do in a month, and look at how the consumables are getting utilized. So you have a projection of how the data is presented. You look into how many cases, and under each of the subcategory, we here have projected a department of cardiology, where you have the number of angioplasties done and what is the overall cost. So they can have a tab on what's happening over there. Going further, you can even look at consumptions by the cost heads under each of this department of each of patient, how much is being, what is the actual cost that is involved. I'm not talking about the price, but what is the cost incurred by us. And also an consumption audit to just look at what are the exceptions. If there is a minimum and maximum standard in general that is set up, what's happening over there. These are some small automations that we have done to look at whether there's no consumption which is expected to be there, or whether it's within the standard limits, or if there's a steady deviation, so that you can look at what exceptions are and possibly adapt, so that there could be a change in practice which needs to be reflected back into the system for us to really know where we are going. So these are about automations for our regular work on a day-to-day basis. Now I'm moving on, shifting the gear obviously to the next, to the AI. If thinking were to be considered as walking up the stairs to reach the first floor, AI is obviously like taking an elevator. So this is some initial work that we had done, which we had in collaboration with Sri Sathya Institute of Higher Learning. So we worked on dosage calculator for INR management. Obviously, it looks into reducing strain and could be helpful in the care or continuum. And other predictive analytics work is in the areas of expediting diagnosis, advancing disease prevention, and improve surgical outcomes, where we were looking at how could we screen cardiogenic brain abscess in TOF patients, particularly coming up with a model that could be utilized in underserved areas where you may not have a specialist over there, but could it have a protocol that could be defined for a primary screening and then having the patients to be referred to a specialist center, look at whether prediction of recurrent lumbar disc herniation or assessing the balloon valvotomy's outcome in mitral stenosis patients. This is a screenshot of a simple app that we could work towards. It's in the initial stages where this could be used even in the SRP centers or possibly as we work together and have more data on it, we could look at if the system can predict what is the recommended dosage for the patient, also possibly look at what is the predicted INR for the following day. Finally, giving a comprehensive clinical audit for the administrators, look at each cost heads and with the overall case types, what is the overall admissions, readmission rates, and look at re-explorations, the mortality, and all put together so that you have a comprehensive clinical audit that could be performed by the doctors. Moving on from these kind of predictive analytics work, the quality indicators that are prescribed by NABH, there are a host of things that have been possible in our systems so that the doctors are able to take it further. So how is all this possible? We have, we call ourselves as the early adopters of IT. It would be a cliche to say we were thinking ahead of age. Bhagavan, in his infinite mercy, has gifted us this organization. And right from 1991, when the Institute of Higher Medical Sciences that got inaugurated in Prashantigram, and Swami has mentioned in his discourse about the 3 A's that are talked about in healthcare: availability, accessibility, and affordability. And then possibly I would add two more A's to it. It is attitude to adopt. So attitude to adopt IT for enabling efficient patient care is something we have been practicing. And this is kind of an evolution of systems that we have had, be it for the health information systems or the picture archival communication system for which we use MedDream. And the latest update has been Atma Health, which maintains our electronic medical record, which is a comprehensive, integrated system that helps us manage effectively the electronic medical record. And the latest to its addition is the advanced data center establishment, which will be taken up by my colleague, Mr. Kannan, in the following, who is the following speaker, next speaker. So talking about compliance, the consent is a cornerstone because IT and its advancement always has a problem. So all the systems that we use are HL7 FHA compliant, DICOM 3 compliance, where compliance is not only in terms of in terms of the regular compliance that we all know about, but even for health IT products, they need to have a compliance. Here I would probably draw upon international classification of diseases, this as everybody would know. It was primarily it was founded for tracking the mortalities and morbidities. But we do have another standard called systematized nomenclature of medicine, because if you were to find a code for I'm always amused at ICD because you do not find the perfect code for anything. It gets classified under 2-3 headings. If I were to look at diabetic retinopathy, it would get classified possibly under diabetes as well as under the retinopathy as well. But here you have SNOMED codes enables clinicians to give a better coding mechanism. Otherwise, you may just find for any other thing, any elsewhere classified. It's a funny way to possibly code a diagnosis. And finally, the way forward for us is from Atma. We are looking forward to implement Adi and Nama, our 2 apps so that it's enabled on the mobile phone for the doctors to use to have access to patient records anywhere. And we look forward to obviously integrating with nations Ayushman Bharat digital mission as and when it comes up. But nevertheless, our product is ABDM enabled to go forward. And the last being the Insights, which is a data lake project, which is a collaboration with our college, university, where we are looking to move from knowledge to augmented intelligence. And AI agent driven solutions for administration and clinician is what we want to go next. So we move from the knowledge pyramid from data to wisdom so that we develop deep understanding and we are able to have actionable insights. Obviously, we have, with all this as a background, we are somewhere there. The Sustainable Development Goals that has been prescribed by the UN Charter, which is the UN, the SDG 3 talks about good health and well-being, where I have listed the outcome targets and the implementation targets. If you look at the outcome targets, we as an organization, we are already focusing on many of these being done. And the implementation target is improving early warning signs for health risk is something our IT systems are capable of and take us closer to achieving our goals, which is even prescribed by the SDG. So, in a nutshell, it's about we are moving from single me, myself to collaboration so that as we together can are able to deliver better patient care. It goes back to what Swami often said, Kalasimelisi Perigudam, Kalasimelisi Tirugudam, Kalasi Melasi Telusukunna, Telivini Poshinchudam. So we all have assembled here to collaboratively possibly come together, discuss, and as a collaborative effort, we are able to make the world a better place. Thank you for this opportunity. Jai Sir.
Om Sri Sai Ram. Loving salutation at Bhagavan's lotus feet, respected trustees, various head of the institutions, brothers and sisters, Sai Ram to everyone. We heard our colleague Subramaniyan just speak before me, telling you about IT and its capabilities and AI. I have come to speak about a different part of IT, which is basically the background, which nobody sees, which is not seen by anybody so easily. Only the IT staff will know. That is the hardware. That is the data center. That's where the whole power of IT resides. It has got the latest servers with huge memory. It has got the latest software running on it with huge storage, which together enables even AI. I'm sure AI nowadays runs maybe hundreds and thousands of computers on hundreds of data centers all around the world. That amount of input and quick processing to process years of data and come out with what you need is the power of the hardware behind it. So realizing this, in the beginning itself, we thought this is a very important step which we take once in a decade. We refresh our whole old hardware, remove everything, and put the new set of servers and storage, which is going to serve us another 1 decade. So this effort was taken up. The first step we did that was to form an IT committee in which this whole hardware will be reviewed, what software will be installed, and what applications will be installed. Everything will be decided by the committee. This committee doesn't include only our internal staff, IT staff, it also includes experts from the industry. And this committee came up with the suggestion that we'll have a centralized data center, which going forward will by design reduce cost and become very cheap because we'll have do no duplicate AMCs, no duplicate license costs on servers, only limited servers which will serve a bigger audience, that is all the hospitals put together, instead of each hospital having its own small island of servers. Then the security wise, if you see, a centralized setup is going to be very, very easy to maintain because nowadays we hear so many hospitals being attacked, so many hospitals network being compromised. All this can be minimized if you have a single data center setup which is exposed in only one place to the internet, that also through a firewall. And we allow only people to connect to our internal hospital network only through a VPN. with the OTP to the mobile so that it cannot be misused by another person at their home in their absence. And use of cloud infrastructure is one big advantage for us now because it enables monthly billing. We need not pay up 20 lakhs, 30 lakhs, or 40 lakhs for buying servers, everything. They will host it for us. We have to only pay a monthly bill, which will be only a few lakhs. So that great advantage we have taken for hosting our infrastructure. Scalability, if it's a centralized infrastructure, scalability is very easy because just by increasing the server capacity, processors, and memory, everybody in the network, all the hospitals, all the users will immediately see a difference in their performance. Unified communications is another very important aspect which can be enabled. Take a doctor, for example. If he's sitting at his house, he can connect to our hospital through a VPN connect through his laptop and see everything about the patient, or he can use Adi app, which you're going to shortly implement from his mobile phone and then see all the patient information or critical information at this moment. And internally, if he's sitting inside the hospital, he can always open the Atma app and then go through all the details. So unified communications, if a nurse wants to put in some information, it's immediately available to the doctor. So like this, a unified communication is enabled by decentralized IT. Next is it's a central repository of information wherein all the data of the patients visiting any hospital of our trust will be centrally stored. Previously, when you had the previous HIS, all of you will remember that you have to go to a separate link to see Whitefield data, or they have to go to a separate link to see our data. It's no more that. It's all one single database, one single application in which everything will appear. Then the planning started to implement this infrastructure. We saw that HIS and PACS were the most important applications which are used in this hospital. And based on that, we did a study of the available databases and web technologies in the market. And then we saw that some applications were cloud ready, like the HIS, whereas some others were not ready for the cloud. I'll explain to you further. So what we decided finally was we'll go for a hybrid plan where some of the servers will be installed on the cloud and some of the servers will be installed in the data center in the campus inside the hospital. Sorry. This timing I'll skip because there's no time now. Audit the existing infrastructure. We quickly audited the existing infrastructure. How much is the servers used? How much memory is used? Which applications are going to come up? Then we formulated a data retention policy. It's very important because as of today, if you see, we have so many years of data, maybe 30 years of data still stored up in the servers, which are very rarely accessed. So the lesser the data, the more faster will be the processing. So we came up with a data retention policy to limit the number of years which is available online. Doesn't mean the data, other data is removed, but it's available on request. It will be backed up. Then we consolidated the type of server applications which we use and also the databases across the hospitals, and both hospital data is put together. Then came the very important part of this whole infrastructure. There is a network. I'll explain to you quickly. See, this is our hospital infrastructure design. You can see on top we have the MPLS here and also the cloud servers here. It's connected to Puttaparthi Hospital and Whitefield Hospital over the internet and network. So network becomes very critical for day-to-day functioning. You cannot exist 1 minute without the network because that's how we are connected to the cloud. So we thought first step we should take is upgrade our main switches, our firewall, which is very critical to protect any intruders from coming in, and also the department level switches, all to support 10G. Currently we are in 1G, now all have been upgraded to support 10G. Then came the Atma implementation, followed by the inauguration of Atma on 22nd September 2024 by our Honorable Trustee. Then we went further to the second part of the plan, which is setting up the physical data center. And we bought 2 servers and 1 storage based on our calculations of its capacity and memory and was installed. This was again inaugurated on 12th May 2025. Then finally, before I close, I would like to say after doing this huge IT project, what is the benefit we are given? IT, as Subramaniyan rightly said, is an enabler. I cannot directly do anything to the patient. What can I do? I can help the doctor not waste much time with computers, but concentrate more on the patient. That means faster response to his queries. So that is enabled by this hardware. And what we did when you chose the hardware, we have to put our effort in minimizing the cost, because every penny saved is going to go in patient care. We are not a what should I say, an organization where we make profit, non-profit. So whatever money I save goes to the patient service. So by choosing free open source technologies, we have saved a few crores in this whole project, above 5 crores. And we have used PostgreSQL instead of Oracle database. Another huge saving. Oracle is very, very costly in this AMC and cost. Then we have Atma HIS in place of EM. This EM was running on Oracle. Finally, we have Medream packs, which is a better technology than the older packs. So way forward, we want to enable Adi app so that doctors need not even move out of their seat wherever they are. They should be able to access our HIS, see the patient data, and respond to the patient in a faster way. Thank you for your support. Thank you, everyone. Sarah.